going forward, I mean, look, I mean, when we see what's happened, I mean, what do you think our fellows are going to be doing in 20 years from now? I mean, are they going to be taking out appendices, full thickness resection? I mean, which is already sort of on us.
Yeah.
I mean, do you see that there will be a separation of minimally invasive surgery and advanced endoscopy? I mean, there's all this talk, but it's hard to sort of bring those two disciplines together.
Yeah. I don't have that crystal ball, but I think there will be much more attention on early diagnosis, for sure. I mean, there are zillions of dollars being poured in for early diagnosis, colon cancer, biomarkers of, you know, I suppose the best thing would be someday when you'll pee in a bottle and they'll tell you everything that you may or may not want to know about your future health. But I think there will still be this niche of the peroral, that sort of mix between the so-called internist endoscopist and the minimally invasive surgeon. That, I think, is still, to me, just hasn't matured yet as to who that hybrid individual will be. Mm-hmm. And I think that, you know, it seems to me there was a lot of interest in that about 10 years ago, and it seems that it's faded a little. Mm-hmm. But you know, technology may change that, and I think that with all this push for early diagnosis, and obviously with it will come prevention somehow. I think that's also a huge nut to crack. But I think the polyps, I can't see, although it would be wonderful, that we're going to take you know, some biological or some vitamin D tablet that's going to change the environment in our gut, and we won't grow polyps, and we will be saved from the anxiety of cancer. So I think that there'll still be polypectomies and early treatment of cancers of the esophagus, the stomach. I think that's still going to be here, and although we may wish and pray for that miracle, I don't think we're going to see it quite around the corner. But it's amazing. Like, look at Barrett's. What's happened? Yeah. Just in the last 10 or 15 years, it's changed from a surgical disease to an endoscopic disease, at least for early disease. And I think that with imaging and biotechnology, I think we can push the envelope a little more and salvage even more cases, like the SM1s and SM2s, where we can maybe have something more accurate to detect lymph node involvement, or have targeted drugs that we can inject endoscopically and knock off the lymph nodes.
Sure.
You know, it's obviously the crystal ball that well, I certainly don't have it, but I think we still have a bit to go with what we're doing now. You know, with the early cancers, you know, EMRs, ESD, that type of thing. Look at POEMS, how that's
Evolved, yeah.
evolved and helped the life of a lot of people with this chronic swallowing disease. What's going to happen with this obesity business with endoscopic bypasses, magnets. I mean, there's a lot of interesting stuff that I see around in abstracts, and so maybe, again, it'll come around, but I think those are a little more complex and not quite as dramatic as what rubber banding did to varices.
Yeah.
Like that was a
Revolutionary change.
bang
Yeah.
done, and in months it was available. These other, I think, will be a little more difficult, and I think there will still be, for sure, the role of the supercenter, the focused, third, fourth level endoscopy unit that will be the focus for access for patients over a wide area and be the important hub for education. I think, and that has to do, and again, the education and the endoscopy and the translational use, sort of that gray zone between developing new gadgets, new techniques, etc., and to do it right next door to the endoscopy unit.
Yeah.
So that, as we did at the good old Wellesley, where we had a room where they were fiddling with the early days of fluorescence and OCT, etc. And under those special things, right across the hall is the endoscopy unit where these can be developed and obviously under very controlled and well-supervised conditions.